So in the ICU, you know every single second counts. And when you're managing these really complex, critically ill patients, you have to know what's going on inside their bodies, like right now. And that's exactly where invasive hemodynamic monitoring comes into play. These are the tools that give us this incredible, continuous, detailed look at the cardiovascular system, helping us guide these life-saving treatments on the fly. So let's break down how they actually work. Okay, so here's a situation I'm sure many of you have faced. It's the classic ICU dilemma, right? You look at the monitor and the numbers look great. I mean, beautiful blood pressure, solid heart rate. But then you look at the actual person in the bed and your clinical gut is just screaming that something is seriously wrong. Or hey, maybe it's the other way around. The numbers look absolutely terrible, but the patient looks surprisingly okay. This is exactly why we have to truly understand the tools we're using. And that really truly gets to the heart of the matter. This quote is pretty much the central theme of our entire explainer today. Technology, it's an incredibly powerful ally, for sure. But it never, and I mean ever, replaces just looking at, listening to, and physically assessing your patient. Those numbers on the screen, they're just one piece of a much, much bigger puzzle. All right, so here's our game plan. We're going to start by moving beyond the simple blood pressure cuff. Then we'll dive into central venous pressure, or CVP. After that, we'll tackle the workhorse of the ICU, the arterial line. We'll even see how some tech, like the flow track, makes that A-line even smarter. From there, we'll take a little journey into the heart with something called a PA catheter. And then, this is the most important part. We're going to tie all of these numbers back to the actual patient. Okay, let's kick things off. We're officially leaving the world of the simple, intermittent blood pressure cuff behind and stepping into the realm of continuous, invasive monitoring. These are the tools that give us that deep, real-time look at what's really going on. First up, central venous pressure, or CVP. The way I love to think about this one, it's basically the fuel gauge for the right side of the heart. It's a really fundamental measurement that tells us all about the volume of blood coming back to the heart, ready to get pumped out. So what is CVP really? Well, it's the pressure that we measure directly in the right atrium. And it's our best direct look at something called right-sided preload. All that means is how much volume, how much fuel the right ventricle has in the tank right before it squeezes. And you can get this reading from pretty much any standard central line. So the normal range we're looking for is somewhere between 2 and 10 millimeters of mercury. But here's the thing, that number is never just a number. It's telling a story. And that story gets really interesting when the CVP is either way too high or way too low. And this slide lays it out perfectly. A high CVP, that suggests the fuel tank is overflowing. This could be because of simple fluid overload, maybe a major backup from something like cardiac tamponade, or the right side of the heart itself is just failing as a pump. On the flip side, a low CVP means the tank is running on empty. You'll see that in things like dehydration, major blood loss, or something called venodilation, where all the blood is just kind of pooling out in the body. All right, let's move on to our next tool, which really builds on this. We're talking about the arterial line, or what everyone just calls an A-line. And its superpower? It gives us a continuous, beat-by-beat, real-time look at blood pressure. No more waiting around for that cuff to cycle every 5 or 15 minutes. So why is this such a game changer? Well, an A-line gives you that direct, real-time systolic and diastolic, plus a calculated mean arterial pressure, or MAP. This is absolutely essential when you're titrating powerful drugs like vasopressors, the meds that raise blood pressure. Tiny little changes to the dose can have huge, immediate effects, and you need to see that. And here's a really key point. As long as your waveform looks good, the A-line is actually more accurate than a cuff, because the cuff is really just estimating its numbers. But, and this is a big but, that accuracy depends entirely on having a good waveform. You can run into two really common problems. First, you might get an underdamped waveform. It looks really spiky and sharp. That's going to give you a falsely high systolic pressure. Or you could have an overdamped waveform, which looks all flattened out. That'll give you a falsely low systolic. In either case, the monitor is straight up lying to you, and you've got to troubleshoot your setup to get a real number. Okay, so we have the A-line. But what if we could squeeze even more data out of that one single line? Well, that's where systems like the flow track come in. This is tech that takes that same arterial waveform and, using some clever math, spits out way more advanced hemodynamic data, all without having to put any more lines into the patient. So how does it do it? Well, there's a special algorithm that analyzes the shape of the arterial pulse to figure out stroke volume. That's just the amount of blood pumped out with every single heartbeat. From there, it's easy to get cardiac output, which is the total amount of blood pumped per minute. But then it gives us this really fascinating third value that kind of helps us predict the future. It's called stroke volume variance. So what the heck is SVV? You can think of it as another way to look at preload, but it's dynamic, it's always changing. What it's actually measuring is how much the stroke volume changes as the ventilator gives the patient a breath. And that variation helps us predict if a patient is going to respond well to a fluid bolus. It really helps answer that million-dollar question: if I give this patient more fluid, is it actually going to help, or am I just going to make things worse? The magic number here is generally less than 13%. And there's a super easy mantra to remember this: high and dry. If the SVV is high, meaning it's over 13%, that's a really strong sign that your patient is dry or low on volume, and they're probably going to get better if you give them some fluids.
Now, SVV isn't perfect. It has its limits. It's not really reliable if a patient has an arrhythmia or if they're breathing on their own. For those folks, we can do a super simple test right at the bedside: the passive leg raise. All you do is lift the patient's legs up. Gravity does the work, shifting blood from their legs back to their heart. It's like giving them a temporary mini fluid bolus from their own body. If you see their stroke volume jump up significantly when you do that, well, that's your answer. They're fluid responsive. Okay, now we're going to talk about the big one. This is our most comprehensive and also our most invasive tool: the pulmonary artery catheter. You'll often hear it called a Swan-Ganz. This thing takes a literal journey through the heart to give us a look at its function that's just, well, unparalleled. So let's trace its path. It's pretty wild. It gets inserted into a big vein, then it travels down the vena cava, goes right through the right atrium, then through the right ventricle, before the tip finally comes to rest inside the pulmonary artery. And it has these little ports all along its length that let us measure the pressures at each stop on the trip.
And here's the payoff, the data we get from that journey. So it measures right atrial pressure, which, hey, that's just our CVP. It also gives us the pulmonary artery pressure, or PAP. But here's where the real magic happens. We can inflate this tiny little balloon at the very tip, and that gives us something called the wedge pressure, or PCWP. And why is that so special? Because it's our best indirect look at what's going on with the left side of the heart. So now we're getting a much more complete picture of the whole dang system.
And with all that data, we can now calculate another super important number: systemic vascular resistance, or SVR. This is our measure of afterload, which is really just the resistance the heart has to push against to get blood out to the body. The best analogy is a nozzle on a garden hose. A low SVR means the vessels are wide open, like the nozzle is completely open. A high SVR means they're clamped down super tight, forcing the heart to work way, way harder to get any blood out.
Okay, so we've got all this incredible data, right? CVP, MAP, SVV, SVR, it's a lot. But what does it all mean? Well, now we get to the final and honestly the most critical step. You have to connect every single one of those numbers back to the actual human being lying in the bed. Just look at this example. On one side, you've got the data: a BP of 85/45, a CVP of 1, an SVV of 19%. Those numbers are practically yelling at you: low preload, the tank is empty. And then you look at the patient. What do you see? Cool, clammy skin, a weak, thready pulse. They're confused. See? The data perfectly explains the clinical picture. There are two sides of the exact same coin. And that brings us full circle, right back to where we started this whole conversation. The absolute crucial takeaway is this: you always, always have to use your own clinical assessment to validate the technology. The numbers on the monitor, they tell you what is happening, but it's your patient who tells you why. And those two things, they have to line up.
And that really leaves us with one final big question to chew on. As all this monitoring tech gets even smarter and more automated, how do we make sure that we're still seeing the patient and not just the data? The challenge for every single one of us is to keep our focus where it truly matters most, not on the screen, but on the person right in front of us.